Good morning. It's March 1st. I'm Jan Dick with the Minneapolis Heart Institute Foundation, and I'm really pleased to turn the calendar to March 1st, but more importantly, to be here with Dr. Gornick to be our presenter today. We really appreciate our sponsors that help make Grand Rounds happen. So we hope that you will have a chance to thank and to connect with our folks from Amgen here today, Tim and Ellie, and then also Laura with Pfizer. It will be with us virtually, and as you know, you have to leave our Zoom meeting and then pop onto that other link that'll be in the chat box. But again, Dr. Gornick, thanks so much for being with us this morning, March 1st.
Good morning and thank you, and very pleased to be here. A little odd giving a talk to an empty room. Can't say that I've done this before, but certainly I'm excited to be here and present. Got a little tangled up in the technology, but we do have everything working properly at this time. First thing I'd like to point out too is the EV-ICD. What that stands for is extravascular ICD. It is a study that we're carrying out. It's a Medtronic device. It's a sub-Q device, but the difference between it and the other sub-Q device that's been available is the lead actually goes under the sternum in that fatty space between the back of the sternum and the heart. That allows the device to actually have some unique detection criteria and characteristics. It also allows the device to deliver some pacing therapy for arrhythmias and also some rescue pacing in case of asystole. Again, the importance of this device is that it is extravascular. So this might be a very good device in someone we're worried about infection, and also younger people who have a long time to have an ICD in place. And finally, it obviously is not something that can be used in someone who's had prior cardiac surgery because there will actually be scarring in that space. Now on to the topic for today. I want to either explain or apologize. I can't decide which. In discussing antidysrhythmics, usually you get up and somebody shows you a whole table of drugs and the Vaughan Williams classification. And my colleague, Dr. Pai, told me if you do that, everybody's going to be looking at their cell phone and checking their texts and emails. So I'm not going to do that. The problem with that approach, now we have 2 slides up, do you? Okay. The problem with that approach is that if you don't have the audience's attention, and since you're virtually all remote, I have no idea whether you're actually paying attention to what I'm saying or not. So hopefully I'm going to make this lively enough and interestingly enough, and I'm going to try to point out some things that I think are unique in terms of drug therapy versus and how they fit into the electrophysiology armamentarium. The first thing, all right, so now I got to do something different to get this to work. Let's see. I think this will work. There. The first thing I'm going to talk about is atrial fibrillation, and I want to begin with a case. I'll present the case in just the next slide, but I just wanted to show, here's a patient's initial ECG demonstrating atrial fibrillation. This was the initial presentation back in 2007. This is a 60-year-old female who's otherwise healthy, without the usual risk factors, but she does have a strong family history of atrial fibrillation in her siblings. We initially met her in 2007. After failing sotalol post-cardioversion, she underwent an AFib ablation. She did well and did not have any recurrence until 2009. And at that time, she actually presented with a tachy-mediated cardiomyopathy and an ejection fraction of 20%. In other words, the first ablation had somehow regularized the rhythm enough so that now I wouldn't say she was totally unaware of the arrhythmia, but unaware enough or not symptomatic enough that she didn't actually present until she had demise of her ventricular function. We cardioverted her and repeated an ablation, and she again recovered left ventricular function. She was on flecainide for a while, but then went off the flecainide and actually did well all the way to August of 2015. At that time, she presented with recurrent paroxysmal atrial fibrillation. As you recall, when she first presented, she was in persistent atrial fibrillation. Sotalol was restarted. In 2017, the patient was having no problems with atrial fibrillation. She wanted off warfarin. Her CHADS-2 VAS score was 2. We recommended that she stay on warfarin, but she was adamant and decided not to. In looking at her CHADS-2 VAS score, I think it is important to say that she actually had a score of 1 for age and 1 for female sex, and the latter is not necessarily a strong predictor, as you are well aware. Unfortunately, within a year, she showed up with an acute embolic inferior myocardial infarction associated with acute mitral regurgitation, and she was back in atrial fibrillation. She underwent a thrombectomy and stenting. She was put on sotalol, now at a max dose of 160 twice a day, and also ongoing warfarin. In 2020, despite sotalol, she was back in atrial fibrillation with not the greatest rate control, and on this basis, she underwent an AV nodal ablation along with BiV pacing for definitive therapy. She was now age 74, and her CHADS-2 VAS score with the embolization and such now was 5. It does show you, though, that from 2007 to 2020, or almost 13 years, she did do reasonably well with various therapies. It also shows you that we do not cure atrial fibrillation with drugs and or ablations. There can be years of hiatus when there is no recurrent arrhythmia, but there's also the fact that we do not cure the arrhythmia. So we're going to talk a little bit about rate versus rhythm control. We're going to talk about the drugs used to control rate, and we're also going to talk a little bit how ablation and drugs work together in atrial fibrillation. If you remember, the drugs that are used to control rate in atrial fibrillation include beta blockers, calcium channel blockers, and even amiodarone on some occasions. AV nodal ablation for definitive rate control with the necessity for ongoing ventricular pacing and potentially the latter's role in promoting ventricular dysfunction needs to be recognized. I'm going to start with the oldest drug, and that's Digoxin. Now, one of the things about Digoxin is there was a randomized controlled trial that was done back in 1997, and this is important because Digoxin is still used today, especially in rate control for atrial fibrillation, and in some cases for progressive heart failure. The overall trial results demonstrated that there was no difference in mortality between the Digoxin versus the placebo groups. However, there was noted a reduced rate of hospitalization, both overall and for worsening heart failure in the Digoxin group. It should be noted, though, that 44% of the patients were on Digoxin prior to the onset of the trial. And how the trial handled that is they had them stop the Digoxin for at least several weeks. Then they were randomized, and then they were either placed on Digoxin or no Digoxin in a randomized fashion. One of the important things about the DIG trial, as it was called or labeled, is that there was no difference in death between those randomized to Digoxin versus placebo. And there was actually reduced hospitalization for heart failure. However, there have been multiple subsequent analyses in a non-prospective meta-analysis sort of analysis of Digoxin and its safety and efficacy. And a German group actually went back to the DIG trial and looked at it as if it were an observational trial. If you look at it that way, it looks like digoxin actually favors a control group in terms of mortality. And I'm going to point that out to you. So here's all these meta-analyses that were done, and all of them suggest that there's higher mortality if you take digoxin. Well, why is that then? When it was actually done in a randomized fashion, was there no difference in mortality between digoxin and placebo? Probably because there's a so-called prescription bias, and that is patients who are prescribed digoxin, it's being done because their atrial fibrillation is not very well controlled and or they're in heart failure, which probably explains why there is a higher mortality in the meta-analysis groups, although that's always speculation. Unless you re-randomized all these patients, you would not know that. But at least a single randomized trial of digoxin suggests that there is no mortality difference, and there is some benefit with digoxin, both in terms of rate control and also in terms of heart failure and heart failure symptoms. So how do we use digoxin now? Generally, we add it to class 3-4 systolic heart failure patients who remain with significant symptoms. Not commonly done, I'd have to say. We do know that it does improve RV function in the setting of acute RV failure. However, there's no good evidence that it improves RV function long term. Probably the most common use of digoxin is as a rate control agent in patients with atrial fibrillation. In the AFFIRM trial, rate control with a resting heart rate of less than 80 and an exercise heart rate on a 6-minute walk test less than 110. And I'm going to give you the drugs that were used and looked at. So first of all, beta blockers alone, about 60 or 59% success. Interestingly, calcium channel blockers alone were only about 38%, and yet they're very commonly used as a rate control agent in singular fashion, which argues maybe we're not controlling rate as well as we think we are. Digoxin alone is actually a 58% success as defined by the AFFIRM criteria. If you take beta blockers plus digoxin, you have a 68% success. And actually, that combination is the most successful in this trial in terms of controlling rate in patients in chronic atrial fibrillation. Calcium channel plus digoxin, beta blockers plus calcium channel blocker, and finally, if you put all three together, you can achieve some additional rate control. How about rhythm control? In the AFFIRM trial, we know that there was no survival benefit in rate versus rhythm control, and we also know that in the rhythm control arm, there were more strokes because patients were taken off their rhythm control therapy. So what is the effectiveness of the antiarrhythmic therapy in that trial? No more than 40 to 60% with antidysrhythmics. Oftentimes, multiple medications were tried and were either ineffective or stopped due to patient intolerance. Now, complex ablation for atrial fibrillation was not included in the AFFIRM trial. And there has been steadily improving success with these ablation procedures, such that with a single procedure now, at least in our program, if you have paroxysmal atrial fibrillation, the success rate for maintaining sinus rhythm, at least on a shorter term, can be as high as 80 to 85%, and in persistent atrial fibrillation, as high as 70 to 75%. Many of you may be aware there was a trial that was started in 2009 and completed in 2019 called the Cabana trial. This was actually headquartered out of the Mayo Clinic, and the lead investigator was Dr. Doug Packer. That trial had a lot of criticism. First of all, it took 10 years to complete and enroll, and so the face of ablation was constantly changing throughout the trial. So exactly whether it was a good trial or not, comparing ablation to drug therapy, and whether mortality would be affected by one system or another, or one treatment plan versus another, truly was not answered by the trial. This slide goes to show you, though, that catheter ablation certainly did better than drug therapy, although at the time many of these ablations were done, you can see that even within a year that only about 60% of patients were in sinus rhythm in the ablation arm, but only 40% in the drug treatment arm. If you look at mortality, it suggests that the catheter ablation event rate was a little bit less, but not statistically so. So this took 10 years. It did enroll a number of patients. It was a trial that was done at a time when atrial fibrillation ablation was being developed and improved, and therefore I don't think it's a particularly valuable trial other than the historical nature of it. Remember the AFFIRM trial that we talked about just a little earlier, rate versus rhythm control in atrial fibrillation, was done back in the 90s before ablation. So is this the new AFFIRM trial? There was a large trial done at 135 European centers enrolling almost 3,000 patients, and this was just published within the last year. And they were looking at rate versus rhythm control and what they called early intervention in AFib patients. In other words, they were looking for patients who went into atrial fibrillation within the last year. And if you look at that trial, it's interesting because about 20% of the patients within the first 2 years actually underwent catheter ablation. So one might argue, why is this trial so much different than the AFFIRM? Perhaps because catheter ablation and its effectiveness has now been added to the armamentarium of treating patients with atrial fibrillation. This trial was actually stopped early after 5 years because there was a reduction in the primary outcome event in more patients in the therapy arm than in the usual care arm. They included in these primary outcomes not only death, but things like stroke, heart failure, and acute coronary syndrome. You might think, why acute coronary syndrome? What does that have to do with atrial fibrillation? Well, remember our first patient actually presented with acute inferior myocardial infarction due to an embolus from her atrial fibrillation. So embolization of the coronary vasculature should not be underestimated as a problem with long-term atrial fibrillation. There were more adverse events if you were prescribed antidysrhythmic drugs, and all of us recognize that most antidysrhythmic drugs, and for that matter, rate-controlled drugs, do have an effect on heart rate, and there is an increased risk of pacing if you utilize those therapies. This just goes to show you, it's a little busy slide, and I don't intend to go over the details, but it just goes to show you how the wide variety of medications that were used, including no antidysrhythmics, propafenone, flecainide, amiodarone, dronedarone, and ablation. And if you look at the right side of the slide, you can see that the majority of patients who were put in the, quotes, usual care arm received a no medication or were in a rate control strategy. So if you look at usual care and early rhythm control in this particular trial, you can see that early rhythm control does win out, but not by a huge margin. And perhaps that's because maybe catheter ablation at a higher rate might have done better. We don't know the answer to that. Certainly in this particular trial, about 20% of patients did undergo catheter ablation within the first 2 years. I think what this trial does help define, however, is the fact that it's probably not a good idea if you go into atrial fibrillation and you wait and wait and wait several years and then try to address it. As we know that there are chronic changes in the atria, including the architecture of the atria and dilatation of the atria, that make it much less likely to be successful the longer you've been in atrial fibrillation before some sort of definitive treatment is utilized. This is a very common, and I'm glad to see Dr. Boppet sitting in the second row. You're called reason a patient in AFib with rapid ventricular response in the post-op setting. Very common on call, and all of the cardiologists have received this call hundreds, if not thousands of times. And cardiac surgeons, I suspect, also. So how common a problem is it? Well, depending on how old you are and what your risk factors are, including age and whether it was valve surgery or not, fully 40 to 50% of patients can have some atrial fibrillation in the post-op period. It usually occurs between day 3 and 5. We know that it prolongs hospital course and cost, and it also increases complexity and management. We do know that beta blocker use before and continued post-op have demonstrated atrial fibrillation reduction in that patient population. We also know that amiodarone, if given 6 days before and continued for 6 days after in divided oral doses, can also reduce the incidence of post-op atrial fibrillation. One of the things about the Papa Bear trial is, again, it was a large trial with nearly 1,300 patients, but only about 600 actually got randomized. But the data were fairly consistent that you could reduce atrial fibrillation fairly significantly. And in fact, in our cardiac surgery program, we have both beta blockers and amiodarone as part of protocol-defined therapies post-cardiac surgery. This just shows you that in the amiodarone arm, there was substantially less, in the range of 15% versus 30% in this particular trial in terms of the incidence of atrial fibrillation. So in summary, amiodarone pre and post-op is the most effective means of reduction of post-op AFib following cardiac surgery. The downside is there's certainly more bradycardia, and there are rare acute liver failure or acute hepatitis that can be associated. We know that beta blockers before and continued post-op can be helpful. We also know that digoxin, because of its lack of significant hypotensive effects, can also be used to control rate in post-op patients. A couple of things I'd point out. If you're a younger patient with a normal ejection fraction, and let's say you're having bypass surgery, your risk of atrial fibrillation is somewhere in the 20 to 30% range or less, and you're going to tolerate it well. So should you be aggressive with something like amiodarone in a patient who's going to do well anyway and risk a small chance that they will develop this acute fulminant hepatitis that can be seen with amiodarone therapy? So that's a challenge. On the other hand, if you're an elderly patient and you're going to undergo multiple valve surgery and your ejection fraction is marginal, then going into atrial fibrillation after your surgical procedure takes on a lot more clinical significance. So clearly there's still a lot of room for clinical judgment in how to treat these patients post-operatively for their atrial fibrillation. Now we're going to talk about ventricular tachycardia and how medical management, including antidysrhythmic therapy and ICDs, because I don't think you can really separate the two. We'll start with this 65-year-old fellow who presents with palpitations. He had a prior MI back in 1999 and actually was stented at that time. He underwent another MI in 20, or June of 20, and underwent repeat stenting of his right coronary artery. In December of 20, he presented with severe palpitations. I'm going to show you the ECG on presentation. And the baseline ECG demonstrated an old inferior myocardial infarction. The echo showed an inferior wall motion abnormality and a mild to modest reduction in ejection fraction. So here's the baseline ECG showing the inferior infarct and also the STT changes, inferior and lateral, associated with that infarction. Here's his initial ventricular tachycardia. He presented with palpitations. In summary, this ECG demonstrates a right bundle branch block pattern with QSs in the inferior and lateral leads, suggesting this is coming from a left ventricular source, inferior lateral wall, fairly apical with QS pattern in V5 and V6. So where does that take us? Well, it takes us to a decision about the AVID trial now. This fellow could be treated with an ICD, he could be treated with drugs. And the one thing this trial, which was published back in 1997, demonstrated is that defibrillators clearly had a survival benefit versus drug therapy. So comparing them head to head, defibrillators were better than drug therapy. In this trial, primarily amiodarone was used, 96% of patients. Some patients received sotalol. I think the next set of statistics are important to keep in mind. In the AVID trial, the overall survival was 89 point something percent for an ICD, 82 point something over the first year, and then by 2 years, 81, 74, 3 years, 75, 64. Well, what does that tell you? It tells you that there's about a 5 to 7% survival benefit for ICD versus drugs. And actually in this group, whether you underwent revascularization or not, didn't seem to change that a whole lot. Now, the AVID trial was done at a time when revascularization was primarily surgical. There was some stenting towards the end, but it was primarily a surgical revascularization time period. Beta blocker use was not associated with survival benefit in this population, although they were commonly prescribed. It is worth noting that if an elderly patient that we see declines in ICD, they're not guaranteeing their death. Remember, there's a 5 to 7% survival benefit of an ICD, but many of the patients who chose drug therapy, or in this trial were randomized to drug therapy, didn't die. And so I think that's an important conversation, especially in elderly patients who may not be all enthused about having a defibrillator implanted versus a younger population. So this is just an overall look at the effectiveness of the ICD versus drugs. A couple things here that I think are important. If your ejection fraction is less than 35%, it's much better. Greater than 35%, hard to prove that it's beneficial. It's very effective for ventricular fibrillation and ventricular tachycardia. It's also more effective if the cause of your heart failure and or arrhythmia is coronary artery disease versus non-ischemic patients. So what about antidysrhythmics and ICDs? In the AVID trial, a full 20% of patients crossed over to receive an ICD or drug therapy along with their ICD. So it's common to treat patients with ICDs with drugs to avoid shocks and also to treat recurrent ventricular tachycardia in patients who have an ICD. Common regimens include amiodarone and sotalol. Mexiletine and ranolazine are common add-ons. The latter drugs are not particularly effective as sole agents. Older drugs such as quinidine are still used, especially in amiodarone intolerant patients. Other medications, including dofetilide and dronedarone, have been used, but with much less experience and also much lower success and strictly on an observational basis. I think this is an interesting study published in 2006. It was called the OPTIC study. And basically what it looked at is various regimens in patients who had ICDs to try to mitigate ICD shocks. And you could see that amiodarone and beta blockers were by far the best if you wanted to mitigate against shocks in this population. Beta blockers alone, not as effective. But interestingly, sotalol had a pretty good effect in those patients that responded to that treatment. So what happened to our patient? Well, he got amiodarone, he had an ICD, came back in now a different ventricular tachycardia, slower, different vectors, still right bundle, still coming from the left ventricle. So we're going to talk about avoiding ICD shocks before we finish with our patient. So it's important to avoid both appropriate and inappropriate ICD shocks. Programming the device with anti-tachycardia pacing can be beneficial. Longer detection times, especially in LVAD patients, and higher detection rates, especially in young patients. I'm going to give you 2 examples. There's a young fellow, 18 years of age, hypertrophic cardiomyopathy, strong family history, history of syncope, risk factors that indicated an ICD was appropriate, was placed at another institution. They programmed their device with a rate cutoff for therapy at 188 beats per minute, which would be standard out-of-the-box programming for the ICD. First thing the young man did was go out and play some pickup basketball with his buds, and you guess what happened? He got an ICD shock. So the family was distraught, the patient was distraught, and quite frankly, it was all because he was programmed inappropriately for a young man in his age group. As soon as we programmed his device to a therapy zone of 220 beats per minute or greater, he became very happy. He could mess around with his buds and no additional ICD shocks. How about LVAD patients? We've learned that LVAD patients can go into ventricular arrhythmias for certain, but we also know that if you program the device too aggressively, they can receive a lot of ICD shocks. In fact, we've had at least 1 or 2 cases where patients were up north with an LVAD, went out of rhythm, got shocks, unsuccessful shocks, continued shocks. By the time they arrived here, progressive RV failure, which led to their demise. So ICD shocks in LVAD patients is not necessarily a good thing. In fact, we've had LVAD patients in ventricular fibrillation that are alert and talking to us. So that's not always, but again, you have to keep that in mind when you're programming these devices. So it's our practice that we try to extend detection as long as we can in these patients. And actually in some new implant patients, new LVAD patients, we ask the question, do they actually need an ICD? And there's mounting data that many of the patients, particularly those with non-ischemic heart cardiomyopathy and no history of ventricular arrhythmias, are better treated without an ICD after their LVAD, or at least there's no survival benefit demonstrated by the ICD. So what about drugs to treat AF and control other SVTs in patients with ICD in place? Probably one of the most common causes for inappropriate shock with an ICD is atrial fibrillation with rapid ventricular response. So obviously we're constantly paying attention to that. We're trying to make sure that when we follow patients that if it looks like they're approaching therapy zones with atrial fibrillation, we try to initiate therapy for the atrial fibrillation, and we also try to program the device such that they will not get inappropriate shocks. Finally, catheter ablation can be very effective in select patients in controlling ventricular arrhythmias. In our patient, he was brought to the cath lab, mapped, ablated, had scar modification, and this was performed with success, and he has gone on now for at least the next several months without any additional therapy or issues with his ventricular tachycardia. So what is the success rate for VT ablation in ischemic cardiomyopathy? Again, we're not talking about cure, but 4 out of 5 patients usually can benefit from an ablation. The non-ischemic population, though, is a completely different story. Ablation can be very challenging. The ventricular tachycardia does not necessarily reside in an endocardial approachable location, and even approaches from the epi and endocardium are not always successful. The other complicating feature of non-ischemic cardiomyopathy is even though they come in with nice ventricular tachycardia, in the laboratory, you may not be able to induce. How about esmolol? And I think this is worth mentioning, that there's some data to suggest that if you're dealing with a patient in refractory VT-VF, you've already given them the IV amiodarone, you've done standard cardiopulmonary resuscitation, that there's some data from the emergency room resuscitation that if you give them a wallop of esmolol, you may be able to actually successfully cardiovert them. And finally, we know that if you intubate a patient who's in incessant VT, it's not only humane, but the VT may quiet down substantially, probably because as with the esmolol, you're withdrawing sympathetic tone and the role that that plays in these arrhythmias. How about other drugs in arrhythmias? I included this slide because I think it's important not to lose sight of the fact that in many of the trials for heart failure with reduced ejection fraction, things like beta blockers, ACE inhibitors, ARBs, all have been demonstrated to reduce ambient arrhythmia. So if you do a Holter before and then you do a Holter after good medical therapy or guideline-directed medical therapy, you will see less arrhythmia in the patients on good guideline-directed medical therapy, particularly in the group with reduced ejection fraction. Here's another problem with antidysrhythmics. This is an ECG obtained acutely in a patient on flecainide. The level turned out to be 1.68, and you can see this is a wide, monotonous sort of ventricular tachycardia. The most important thing to recognize about this ventricular tachycardia associated with flecainide or type 1C antidysrhythmics are just sit on your hands. Don't do anything until the flecainide goes away. If the patient is hemodynamically reasonably stable, waiting is the right treatment. Adding another antidysrhythmic such as amiodarone can lead to hypotension, further QRS widening, and the patient's demise. Cardioversion is very unsuccessful. The rhythm tends to be incessant and just recurs. So this is what the ECG in this patient looked like after flecainide withdrawal. She is in an atrial-based pacing rhythm with a narrow QRS. So what about flecainide toxicity? You'd say, well, geez, you know, if we know that, it shouldn't happen very often. Actually, I've seen a couple of cases in the last couple of years. As you know, it's a use-dependent drug. We always monitor the PR because it does affect AV nodal conduction, and it also affects interventricular conduction, so we look at QRS duration. If you have a patient that has some QRS widening on flecainide or propafenone, it's not unreasonable to just put them on a treadmill and see if it further widens as they increase their heart rate. One of the things that's not recognized about flecainide is that it's renally cleared about 35%. Thus, you can be on a stable dose that's been working for years and then suddenly have a decrement in your renal function and develop acute renal and develop flecainide toxicity associated with that fall in renal function. And in fact, in both cases that I've seen recently, one was on a stable dose of flecainide, developed acute renal failure, flecainide toxicity. The other one had a combination of both increasing the dose and renal insufficiency, leading to flecainide toxicity. Again, when I say sit on your hands, there's no good way to get flecainide out of your system. It's not dialyzable, it's not anything, you just have to wait. How about antidysrhythmic drugs in pregnancy? I was asked about this, or at least a comment. There's two sort of populations. So we're treating maternal, right, or we're treating the fetus. And to be honest with you, we end up doing both here. And if you want to treat the fetus, you need to deliver high levels or high doses to the mother so that you can actually get appropriate levels to the fetus. In other words, it's almost like we're poisoning the mother to affect the baby with these drugs, and to some extent, there's some truth to that. We usually monitor the mother, and the pediatric cardiologist next door monitor the baby in terms of the rhythm and the rhythm response. So we work as a team most of the time when we're treating fetal arrhythmias. On the other On the other hand, maternal arrhythmias are also important, especially as we have more patients who have repaired congenital heart disease that actually have arrhythmias. And there are some arrhythmias like atrial fibrillation and atrial flutter and some SVTs that we can see in pregnancy that were not a problem until the mother was deep into pregnancy. And so we carefully pick and choose medications that we feel are both safe for the mother and for the fetus. Obviously, we always try to avoid drugs in the first trimester when fetal development is most important, and there's more likelihood that a drug could have an untoward effect. Just remember again, when you're dealing with a mom with a baby with a tachycardia in utero, we are really poisoning the mom, and some of them can actually get quite symptomatic from the side effects from the antidysrhythmics that we're giving. But it's interesting how much the mothers are willing to put up with if they think they're helping their baby. Again, we see a lot more problems now with, we have patients with ICDs in place, congenital heart disease patients, and as you know, we do have a cardio pregnancy program. Dr. Saxena, Hahn, and Moore, along with the ICU doctors and myself, have been involved in the care of most of these patients. Also, our surgical team. We've had surgeons on standby. We've had ECMO on standby when we deliver some of these patients who are a challenge. So, for example, we just had a young woman, 26, mechanical mitral valve, was being monitored out in South Dakota, developed acute thrombosis of her mitral valve, was emergently transferred here, was anticoagulated. Fortunately, she was far enough along in the pregnancy that the child was delivered, and then the patient actually went to surgery to have her mitral valve replaced and also declotted. The replacement was indicated along with the declotting because it was a valve that actually had been placed when she was 13 years of age. So obviously, she had grown substantially in the next 10 to 13 years, and now the valve was relatively small for her. So that probably also contributed to the fact that it clotted. Not only the anticoagulation issues, but the fact that it was too small a valve for the gal now at 26 years of age. Finally, just in summary then, I tried to stay away from just repeating the Vaughan-Williams classification. You've all seen that, I don't know, dozens, if not more times. I thought I went through treating drugs that we use commonly to treat cardiac arrhythmias. And I also thought we looked, at least this morning, at some of the common issues that we encounter as electrophysiologists. As always, I believe we're very fortunate in our practice. We have an excellent cardiac arrhythmia service. We have excellent surgical service. We have imaging service. We have heart failure services. We have structural services. We have interventional services. We're not for lack of good knowledge and good expertise in virtually all areas here at the Minneapolis Heart Institute, which in some ways I really feel a privilege to practice here because we have so much support from all of these areas. So thank you, and if there are any questions, I'm happy to entertain them. Go ahead.
Can I start? So I would like to ask you first is the post-op AF, atrial fibrillation. As we know, the incidence is pretty high. The two institutions where I practiced before, we used to always keep the potassium levels at a reasonable level, that is above 4 generally. And then interestingly, the use of diuretics at the same time was never intravenous, because we know that intravenous diuretics used can drop the potassium levels very fast as well. Here I've observed that we use intravenous diuretics and our potassium levels are usually below 4. Do you think levels of potassium are pretty important, especially in the acute post-operative period, to reduce this incidence? I mean, these are easily correctable measures in terms of reduction.
The answer to your question is I don't know, and I'm not aware that it's ever been systematically studied. I do think that we spend a lot of time in our institution looking at preoperative weight and deciding that the patients are up some fluid weight, and we're aggressive at diuresing them. And I've never exactly understood why we do that if they're not short of breath or there's other clinical indication. Because as you know, in most postoperative patients, they will diurese on their own if you just give them the opportunity. So unless there's signs of frank congestive heart failure, I would tend to favor your approach, and that is less diuretic, allow for the fact that there's some fluid overload, which is typical postoperatively. And I do think keeping potassium and magnesium levels high or greater than 2 and 4 are probably a good idea.
My second question is, arrhythmias and anticoagulation tend to go hand in hand, whether it's rate control or maybe even rhythm control. What is the current philosophy for atrial fibrillation? Is it NOACs or is it warfarin?
The answer to that question is, if you look critically at the data, the DOACs are a little bit, maybe a little bit more effective in preventing stroke, slightly, and that I just want to emphasize that. Their biggest claim to fame is that there's less CNS bleeding with DOACs. On the other hand, if you look at the majority of our patients, now we're talking about a reduction of untoward events with a DOAC versus warfarin in the range of 1 to 700 or something like that. So a big challenge for us is that warfarin, it costs you about $6 or $8 a month for the medicine. Your health insurance pays for the INR measurements. DOACs could be as high as $200 to $300 a month for patients. So that's the challenge right now. So would we be better if the costs were more equal? The answer is yes. But it's very hard to argue that a patient should take a medicine that's 20 or 30 times more expensive than warfarin with that limited potential benefit when their out-of-pocket expenses are such that it's not affordable for them. So I hope I'm answering your question, but that's what we deal with every day. Now, of course, you do realize that in the surgical literature, it's actually advancing. So, for example, we used to say that non-valvular atrial fibrillation. Now, what's non-valvular? You didn't have aortic or mitral valve disease. Now it's gotten such that even if you've got a bioprosthetic valve in the aorta or mitral, that DOACs may be utilized. Certainly mechanical valves, the studies have been done that demonstrate the superiority of warfarin, but not, and of course patients get a bioprosthetic mitral valve and they're real keen on going back on their DOAC, as you know. Now, we don't have as solid data for mitral as we do an aortic valve bioprosthetic replacement, but I can see that data forthcoming. So.
Any questions from
Must have answered all the questions.
I have a few more, but.
Well, I didn't see anybody here looking at their cell phone, so I must have done partially okay. All right.
Dr. Papat has
I have a lot of questions actually, because this is an area as a surgeon, I think we are always deficient, I would say, during our training period, and post-operatively we are focused on very few issues. You touched upon a very important case, is the pregnant girl who came with mechanical mitral. This has been observation since many years now that there's a switch in the OBGY community to shift the patients from warfarin to DOACs, low molecular weight heparin, which has never been proved to be good in mechanical valves. These patients are not monitored. If we are switching them, this is an inevitable complication, in fact. And I just feel that there's a need for education on their community. Plus, if we are switching them, maybe monitor these patients every monthly properly. to avoid such disasters. These are precious pregnancies. A lot of effort is put in, and where we lose is the anticoagulation switch, which happens.
So in the patient that I just spoke of, she was actually appropriately, well, first of all, warfarin in the early trimester, there have been some pregnancies that have been carried with warfarin levels at less than 5 milligrams a day without changing the warfarin. But whether or not that's a good idea is, you can argue. There certainly is increased fetal abnormalities in women taking warfarin with mechanical valves in the first trimester. So there are several approaches that are used. One approach is to take them off the warfarin prior to getting pregnant and then transitioning them to BID Lovenox and then to follow anti-factor 10A levels. Another approach is to take them off warfarin until the first trimester is finished and then put them back on warfarin through the remainder of the pregnancy. Our patient, or the one that we just talked about, was actually on Lovenox and they were following levels, but exactly why they chose to, she was on 80 milligram twice a day, which is, it's generally more than a milligram per kilogram in those, because pregnancy is a hypercoagulable state. They reduced it to 60 and then presumably they got levels. We didn't have the levels available to us to review, but then they further reduced it to 40 and that's when she presented. So I don't understand the rationale. If you're following factor 10A levels, you want to err on the side of being over-anticoagulated with a mechanical mitral valve, not with the likelihood, as this happened in this case, that she became under-anticoagulated with an undersized valve. And I mean, it was touch and go. This young woman suffered a stroke. She had to have an MCA cleaned out by the interventional radiologist. I mean, this was not trivial. In fact, it was life-threatening to both baby and mother in this particular case. So I think, again, there's a lot of expertise in our hospital regarding anticoagulation, possibilities and whatever. I hope we do a pretty good job from day one, but obviously as a quaternary center, we're going to see all comers from other health systems and other places. Not to be critical, I mean, if you think about a community hospital, how many patients do they see like this? So it's easy for us to be critical and say, well, we would have done it differently. But we're not a community hospital. We're a quaternary center that has all of these resources at our fingertips. That's not true in the community. And I want to emphasize that.
Last question from me, just this is out of curiosity, is what are the battery lives now of a pacemaker, a dual chain pacemaker, and a defibrillator? What should a, when we see patients and we quote them some duration, one of the questions asked is, Dr. Ma, but if I need a pacemaker, do I have to undergo this every 5 years or 7 years?
Okay, so for a single or dual chamber pacemaker, the longevity for the battery should be 10 years plus. The micro, which is the leadless pacemaker that we put in some occasions, should be 8 to 10 years plus. IV, either ICDs or pacemakers, historically were at 3 to 5 years, but now are more in the 6 to 8 year range. So pacing the left ventricle does have a battery cost. But again, it is getting better. The sub-Q ICDs are similar to the single chamber ICDs in terms of their longevity.
All right. Thank you.
Thank you.
Thank you
You're
so
welcome.
much.
Now, in terms